Well, hello everyone, and thank you for joining us for this session on long COVID. I'm Kate Donachie and I'm here with Carly Forrest. Carly and I are lawyers in our Health and Safety Claims Liability Defence team. Our webinar today will attempt to clarify what is known about long COVID and what the future might hold. To help us with that and to provide expert insight, we're joined today by Dr. Laura McWhirter. Laura is a consultant neuropsychiatrist. She has a particular interest in functional neurological disorders. She's a research fellow with the Centre for the Clinical Brain Sciences at the University of Edinburgh, and she has recently been named as principal investigator on a grant from the NHS Scotland Chief Scientist's Office to establish the observable traits underlying cognitive symptoms in long COVID. So hello, Laura. Thank you very much for being here virtually with us today.
Thank you very much.
For those of us who might be unaware of them or just not sure quite what they are you able to tell us what a functional neurological disorder is?
Sure. So in functional neurological disorder, patients have neurological symptoms, a whole range of things really, like weakness, numbness, sensory loss, sometimes seizures or seizure-like episodes, tremor, just a whole range of things, memory problems, speech problems. But rather than being due to disease or kind of structural damage to the brain, they're due to sort of disturbance in brain function. And that means they're potentially reversible in some people, but they're due to a range of things. And we're starting to understand a wee bit better some of the kind of brain processes that are involved in causing those symptoms.
And are they common? Is this a condition that affects lots of people, or are they quite rare?
It is actually really common. So in studies that have looked at patients attending neurology outpatient clinics in hospital, we found that functional symptoms are present in probably about a third of people, including people who also have other conditions. So people who perhaps have things like MS or motor neuron disease, but also have an element of a functional disorder as well. But as a sole cause for neurological symptoms, yes, they're very common actually.
Right. And I suppose one of the issues then is that they're not very well known about by the general public, at least, or understood. And does that pose problems?
Yes,
for you?
Yeah, absolutely. So, you know, we tell people often, we say, "Oh, this is a common condition. We see a lot of this," but pretty much nobody has ever heard of it. So yeah, I think that is a problem, and certainly they've been not very well recognised even within neurology until maybe the last 20 years, when we've started to, you know, these used to be perhaps termed psychogenic or medically unexplained symptoms, and really coming around to this understanding of these as something positive that's going on in the brain. That's quite new. So neurologists now are much better at making diagnoses and understanding what's going on. But yeah, I think that hasn't quite reached the general public, and that can be a problem when you're explaining to somebody what the cause of their symptoms is.
Yeah, and that could have an impact maybe on their ability then to be not cured, but to be treated. If they're not understanding what it is that is wrong, then presumably that can have a detrimental impact on the effectiveness of treatment. Or
yes, absolutely. And one of the things that we know is that having kind of a good understanding and being, you know, suitably convinced that that is what's wrong is kind of necessary for you to be able to do well with any treatment that we provide. What tends to happen is people who really don't think that that's what's wrong or remain convinced that there's something else going on, it's quite difficult for them to kind of benefit from the treatments that we offer.
So there's a lot for us to be done to sort of boost further all of our understanding of these conditions.
Yeah, absolutely. Mm-hmm.
And Carly, I think we can probably predict fairly confidently that long COVID is going to pose challenges for businesses and employers and their insurers.
Well, yeah, I mean, yet another challenge facing businesses and employers. And I think we've talked a lot over the past 9 or 10 months about the steps businesses and employers need to take to protect themselves against claims. And that's from members of the public or, you know, those affected by their undertaking, and of course their employees, to be able to risk assess and take the necessary steps to reduce the risk of people contracting COVID to the lowest level reasonably practical. But despite this, we know that clients have started to receive intimation of claims from COVID, and we know that a number of claims management companies have been set up specifically to target this market. So claims might be those from direct infection or indirect claims from issues like home working. And we've talked before about the musculoskeletal problems from not having correct equipment. But mental health issues is one that I think is worth flagging, because it's interesting that common symptoms of long COVID or post-COVID-19 syndrome include things like fatigue, brain fog, loss of concentration, memory issues, headache, sleep disturbance, symptoms of depression and anxiety. And I suppose those symptoms are all those that you might expect to see in someone who's suffering generally as a result of the lockdown and the fear factor of catching the virus, and therefore making them feel more isolated. So I think for those who are more vulnerable, I wonder whether long COVID is a thing, does that perpetuate the problem? I think we're all aware that the lack of interaction with others can have a huge impact on mental health. So I think from an employer's perspective, we really need to be on notice for this, and be checking in regularly with employees, particularly those working remotely and those who live alone or they've got additional childcare or caring responsibilities, and put measures in place. If that person is struggling to cope, then measures will depend on the occupation and type of industry, but it might include occupational health, treatment, flexible working, reduced hours, or looking at workload, and really making sure that there's a strong focus on the well-being side of things, and as much as there is on the physical side of things.
So I suppose it's just moving, maybe our focus has been so much on protecting people from being infected, and there's a much bigger, more complicated picture perhaps going on, and with lots of different things feeding into it. But I suppose the diagnosis of long COVID is also going to create issues in the claims context, because it's a new condition, in terms of predicting what the outcome or prognosis might be for someone who has long COVID. Do you think that is an issue we'll face soon, Carly?
Absolutely, and Laura's already touched on it in terms of just the emerging picture of, we know now a lot more than we did to begin with about functional neurological disorders, and long COVID is the same. And I think further down the line, if we think about the impact that long COVID might have in someone's life, where they suffer, say they suffer a subsequent unrelated injury, that person's already vulnerable, so they might not recover in the same way someone would without those pre-existing vulnerabilities. So they might struggle to recover, as you might expect, and particularly in the context of someone with more serious injuries.
And I think we might also see issues with care, the cost of care. So that might be higher now than it might have been beforehand, because the needs are different and more difficult to meet.
Yeah, I think the cost of care is something that's always increasing. It's the largest head of claim by far in the majority of the CAT claims that I deal with. And so yes, so I don't think this will just relate to traditional care models, but also the cost of actually obtaining input and treatment from mental health professionals increasing also. I suppose the only thing I would add is it goes without saying that all of what we're talking about is claims where liability and causation are established, but we're going to be dealing with those issues, so we do need to be aware of them.
Yep. Okay, well, there's clearly a lot to think about here. We're going to pass over to Laura now, who's going to speak to us about long COVID and what we know so far.
So yeah, thank you very much again for asking me to speak. So long COVID, I know that COVID is kind of all that we've all talked about for the last year nearly. I'm going to talk a bit about long COVID, and a lot of this is quite new. But what I want to kind of concentrate on is what's new, but also what we're familiar with from things that we've dealt with before. And I'm going to talk about how we might figure out what's going on in terms of causation and treatment and prognosis for any individual patient. So here it is under the microscope, and just a quick recap. So coronavirus is the name of the kind of type of virus this is, and they were actually, interesting story, they were discovered by a Scottish virologist called June Almeida in 1966 with electron microscopy. SARS-CoV-2 is the name of the specific virus, which was found in Wuhan in December 2019 in a group of patients who were very severely ill in hospital. And COVID-19 is the name of the disease resulting from infection with SARS-CoV-2. So And coronaviruses aren't new. So as a group, they're probably responsible for about 15% of cases of the common cold. But this is obviously new, and both from a kind of biological point of view and psychosocially. And thinking about the pathophysiology, with SARS-CoV-2, it's a bad combination of being highly transmissible, contagious during a pre-symptomatic period, so you can spread it around before you know that you've got it, and also you can spread it around during completely asymptomatic case, so it's quite variable, and associated in about 10 to 15% with the severe respiratory illness and critical illness in around 5%. But it's also new because it's not just the respiratory syndrome that we see. So it's associated with symptoms in really almost every part of the body, probably secondary to a kind of immune activation. You get what's called a cytokine storm. And some of these seem kind of quite alien. So one of the most specific early symptoms is loss of sense of smell. And sometimes when that returns, people get a kind of distorted sense of smell. It can be quite unpleasant. You get gastrointestinal upset, skin rashes, you get this thing called COVID toes, where it's sort of a bit like chilblains, eye problems, just really a whole range of symptoms. And I'm a neuropsychiatrist, so I'm particularly interested in the neurological complications. And this was really the first paper, a surveillance study published in June 2020, looking at neurological presentations of acute COVID. So this is not long COVID, but acute COVID. And what they found was that a small proportion of people had encephalitis, so a sort of direct inflammation of the brain. Some people had new psychiatric diagnoses, including psychosis and things, and some people had stroke. And it seems, as things have panned out, that stroke is probably, that is one of the risks of COVID, because it the inflammation going on seems to make your blood stickier, more coagulable, more likely to have blood clots, both in the legs, the lungs, and in the brain. But what this kind of study can't tell us is how, or couldn't tell us, is how common these things were and how directly they were related to SARS-CoV-2, or non-specifically to kind of critical respiratory illness, or to pre-existing disease, as we know that people with pre-existing diseases were more likely to get sick, or also side effects of treatment. And that's something that we've seen a bit more of, as dexamethasone, which is quite a strong steroid, is now used for a lot of treatment. And we know that steroids can cause psychiatric side effects, among other things. But also psychologically, this is something new. So we've been living in this kind of state of heightened alert for nearly a year. And this is actually from a picture from ET. But I think, you know, in the hospital, we're seeing the plastic sheets, colleagues wearing a lot of PPE. And, you know, it is all quite frightening. And the other thing that happens as a result of that is we're all worried about getting ill. Generally, we're getting probably, you know, we're a lot less exposed. I've got young children, and there are a lot less colds and coughs and temperatures in the house than there used to be. So when you do get anything, any kind of symptom, you think, what's going on? Is it COVID? Am I going to have to go to the airport and get a COVID test? You know, and we're frightened of getting ill. We're frightened of, you know, if you've got a tiny bit of a sore throat, what if you have COVID? What if you've passed it on to somebody? And I think it causes, I stole this off Twitter, but it is causing this kind of hypervigilance to bodily symptoms that is a bit, you know, it's a bit new for a lot of us. And there's also this uncertainty around our kind of day-to-day activities. So at the worst, I know people have had terrible problems with losing employment, income, but even those of us kind of privileged enough to retain our employment, there's been changes in our role, working from home, doing homeschool at the same time. And, you know, certainly at the beginning, I was terrified. I updated or got new editions of all my general medical textbooks because I was convinced I was going to be redeployed to a respiratory ward or something. And I'm very relieved to say that they all remain pristine and unopened. But, you know, it's something we're all subject to, that kind of anxiety, what's going to happen with work. And it's easy to forget, because we're all going through something similar, that we are in this heightened state of vigilance and alertness. And I'm sure I'm not alone in when you get the phone thing coming up on your phone, that BBC News flash, thinking, oh, what's it going to be now? What's this time? And I think in my clinical work as well, I'm a clinical neuropsychiatrist. I see patients in the neurology and neurosurgery wards. I'm seeing a lot of the kind of indirect impacts of people who have lost their usual supports, people who are more isolated, who are drinking more, becoming depressed. So there's, as well as the disease, there's these kind of general psychosocial consequences and this general state of alert that we're all in. Now, moving on to kind of long COVID. So we recognized really quite early on that some people were staying ill for a long time after the acute period of illness was over. And the first we saw of this was a letter in the Journal of the American Medical Association last April, May, I think. And that reported that nearly 90% of patients who had been hospitalized with COVID still had symptoms after 60 days, and 55% had a lot of symptoms, and 44% had a worsened quality of life. Now, I suppose you might expect that from, the pictures from Italy of these people in intensive care were really distressing at the time, and you might expect people who had been that ill to still not be feeling back to normal 60 days later. But as time's gone on, it's become apparent that it's not only those people who are admitted to hospital, but also people who have had what has been called mild COVID, and they were first called the long haulers and now increasingly long COVID. And just to touch on, and Carly mentioned some of the definitions earlier, so the early NICE Sign College of General Practitioners guideline suggested that symptoms lasting for more than 4 weeks were called long COVID, and symptoms lasting more than 12 weeks were a post-COVID syndrome. But actually, there's probably no real pathophysiological basis for that cutoff. It's not that symptoms occurring at 11 weeks are the remnants of COVID and symptoms at 13 weeks are something different. It's probably, much more of a grey area than that. And I think a lot of us are just using long COVID now to describe this syndrome. And I quite like it. I think it would be good if we could talk about long pain instead of chronic pain. Chronic means a lot of different things to different people, whereas, long, it tells you what's happening. And again, a bit difficult to look at the prospective data on how common this is, because data has been collected from, so for example, the data from the symptom tracker app, which a lot of people have on their phones. I don't know how many people are still putting data into that, but that suggests that about 1 in 10 people with COVID are sick for 3 weeks or more. And there are other studies which are primarily of people who are reporting that they do have long COVID. And so it's difficult to tell, but I think it's generally accepted that it's probably about 10% of people are going on to have problems beyond about a month, and some of them going on well beyond that. And that kind of rings true with experience in other infections and things as well. So it looks like this is going to be a really big problem, especially in the UK, where our infection rate is really high. And worldwide, it's going to be more than 5 million people affected with sort of long COVID. So what is it? So this slide is from the Long COVID SOS, which is a kind of pressure group which was set up quite early on. It's worth having a look at their website. They're very well run, actually. And we've had some help from some of them in developing our research proposal for the grant that Kate mentioned. And this was a campaign they did, and they're each holding up a list of their symptoms. And the symptoms reported are numerous. Probably the most prominent ones are fatigue, kind of brain fog, dizziness, palpitations. There's this really prominent variability, so people can have a good day and then feel completely wiped out. But really, again, symptoms in every system are included there. And I know that this is probably impossibly small to see, but this is from what I thought was quite an interesting study. And again, a bit biased because this is recruited from support groups and social media and things, but 3,762 respondents, and they looked at what symptoms they had at what stage, starting from week 1 and moving up to month 7. And what they identified was they said there were 3 clusters, but really what you can see here is right up at the top, the symptoms listed: fever, loss of appetite, dry cough, vomiting, rattling of breath, sore throat, runny nose, elevated temperature, diarrhea. So I really think that they're just symptoms of COVID. They're symptoms of COVID infection. But as you move down, they get much less specific in affecting a lot more symptoms. So we've got abdominal pain, fatigue, headaches, bone ache, sleep apnea, insomnia. And really, by the time you get down here, I skipped on. By the time you get down here, just every symptom that you could think of: memory problems, new allergies, bladder control problems. really a wide range of symptoms. And that suggests to me that what we're seeing early on is a bit different from what we're seeing in the kind of middle term, and a bit different again from what we're seeing quite late. These are probably overlapping but slightly different groups of people. But it's implied kind of in the way people talk about long COVID that either after having COVID you get better quickly, or things drag on a bit and then you get long COVID. And it's sort of implied that this is a single condition. And I don't think that's really going to be the case. I think what we're going to see is a lot more like this, a lot more complicated. So it's going to sort of depend where people have come from, what they've been like before, what kind of an illness they've had with COVID. So whether they've been mildly affected, whether they've been, if you've been ventilated for a month in intensive care, if you've had, say, even ECMO, where you've been on the extreme support, you're going to have a very different trajectory. And then what happens afterwards, again, is going to depend on before, it's going to depend on what sort of supports are around you, your sort of living situations, employment, a whole range of things. So this is a bit what I think it might look like with some of these different tracks, these different clinical presentations, and how I'm going to talk a bit about some of these and how we might identify which one somebody is on. But what I want to emphasize is this is not exhaustive. There are lots of other things that I think will come into the mix. So kind of starting up at the top. So the common experience here for most people is acute illness with COVID-19. We know that a minority of people will have very severe illness. Some people will have strokes. Some people will have this kind of encephalitis, and that really probably is a minority. As time has gone on, it's seen more that that's a minority of people. And they are going to have persistent symptoms, and they might have weakness, speech problems, language problems, the sorts of things that you classically see after a stroke. And encephalitis, probably more diffuse kind of general cognitive difficulties. Now, how are you going to tell that this is what's going on is that when you look back to the person's acute illness, they're going to have generally been hospitalized, they're going to have been very unwell, extremely confused, and the rule is generally gradual improvement, as it is for stroke and any other kind of a brain injury. So this is kind of thinking the realm of brain injuries, and people generally, they get better and better over time. Whether they get back to normal or not it depends, but they do tend to get better. Now, moving on to the blue line here. So delirium is the most common neurological presentation of COVID, and that is characterized by disorientation, inattention, so difficulty concentrating, and kind of fluctuating, or it's sometimes called clouded consciousness. So people can be quite agitated and confused, or they can be just kind of quiet and withdrawn and disorientated. Now, delirium is a non-specific sign of brain dysfunction, and all it tells you is that somebody is very ill. And if you're healthy and you have a bad illness that makes you delirious, you're likely to get better and to pretty much get back to normal. If you are elderly, if you've already got some disease in the brain, say if you have some early Alzheimer's disease in the brain that has not yet become clinically apparent, then it's more likely that you're not going to make a full recovery. You might, but it's more likely you won't make a full recovery. And then it's going to look like the COVID illness here has caused a new sort of dementia syndrome, when actually what's just happened is that it's kind of anticipated. It's skipped you forward a wee bit on your disease process. And we think that a proportion of the people who develop cognitive decline after COVID are going to be people who were kind of just about to get dementia anyway, due to Alzheimer's disease or some other kind of brain disease. And the other thing that we do see also in healthy people after delirium, and I know they saw quite a lot of this in the 2003 the SARS outbreak, is people who have been in intensive care, they've been confused, and they've been very frightened, developing a kind of PTSD, post-traumatic stress disorder. And it's a bit different from post-traumatic stress disorder after, say, a car accident, because muddled in with the kind of genuine memories are these kind of hallucinatory experiences, kind of nightmarish things that they remember happening that didn't happen when they were in hospital. And I think that's probably made worse by all the PPE that happens. You've got people moving around you who are covered in suits and things. And really important to identify that, because it's going to make everything else worse. If you've got PTSD, it just makes it very difficult for you to move forward in any kind of recovery from anything. So important to identify that. But as I say, most people with delirium will get better and jump onto the green line and progress to a full recovery. So moving down, so I'm not going to talk too much about this, but we know that a lot of people who've had COVID, it's just a bad illness. It's for most people, even who have what we call mild COVID, this is going to be like the worst illness they've ever had. And the people I know who have had it said, oh, it's 10 times worse than flu. It's just really awful. And you're going to expect to have symptoms that go on for several weeks. And I think 4 weeks, actually, I think if you've had a really bad flu, you're probably going to still be symptomatic at 4 weeks. And this is similar. But people are getting persistent respiratory symptoms, still short of breath, still a cough. And there are also some cardiac side effects. You can get inflammation of the heart muscle, myocarditis. Palpitations are quite common. And some of these are just the kind of expected result of being ill, and some of them are probably directly related to COVID. But people who've had severe respiratory disease, there will be a minority who will go on to develop chronic lung disease, especially those people who've been ventilated. And that's probably common with other causes of needing to be on a ventilator. You're not probably your lungs are probably not going to get right back to normal. But I'm going to kind of concentrate here on the green line. So the bulk of people with long COVID, the bulk of people with COVID make a full recovery. I want to emphasize that. Most people get completely back to normal. But as I say, it's probably still going to be one of the worst flus that they've ever had, unless you've been very lucky to have a very mild illness. What we are seeing is some people developing patterns of chronic fatigue, and that might overlap with some of these persistent respiratory symptoms. In older people, it might overlap with a bit of, a bit of cognitive impairment that we would hope to resolve. But this pattern of chronic fatigue, where it's not due to permanent damage or disease, but there's this distinctive pattern of reduced exercise tolerance, getting really exhausted after minor things. And we've seen this before with, we see this in people who've had other viruses, things like Epstein-Barr, we've seen after flu. I know that fatigue was common after the Spanish flu in 2018. So it's not new. And it probably has, in part, an inflammatory trigger. So you've got all these kind of inflammatory mediators flying around your body, and they can sort of trigger off this fatigue. But it's almost certainly maintained by these kind of, and a lot of people by these patterns. So it's quite variable. You have a good day, you do as much as you possibly can, you clean the whole house, you go for a run, and then the next day people feel absolutely wiped out in a way that they never have before. And then so they sort of lay up, go stay in bed, or maybe just have a quiet day, quiet couple of days, and then it happens again, and you get this boom bust cycle. And what happens with that is that your tolerance on a good day goes down, and the gaps between it doesn't really show this well, but the gaps between it get longer, so you're needing more rest, and then on good days you're managing less and less, and you're really overall your exercise tolerance, your kind of fatigue tolerance goes down and down. And I think this is particularly common in people who've been quite high achievers, who've done a lot, people who are quite kind of perfectionistic and are keen to get back, and they're just really prone to doing this, kind of overdoing it at the start, because they can't tolerate the idea that they won't be back to normal yet. And actually we see this pattern in all forms of fatigue. We see this in multiple sclerosis, we see this in patients who have a whole range of neurological disorders, and the treatment is the same for them as it is for people who have fatigue after a virus or another condition. And that is just to really gradually, so to do less than you think that you're able to do, and then the next day to do a tiny bit more and a tiny bit more. So really, really sort of graded exercise, really gradually increasing things without these peaks and troughs. It's difficult for people because it's less than they want to do at the start, but overall the effect is that you increase your fatigue tolerance. And moving on from fatigue, and to say these bottom two conditions, there's a lot of overlap here. So most people with functional neurological disorder also have fatigue. Some people with fatigue will have some symptoms of functional neurological disorder. But in FND, what we see is people who have prominent symptoms like dizziness, weakness, tremors. They might be having blank spells, and very commonly as kind of brain fog, impaired memory and concentration. And again, this is as a result of these potentially reversible changes in function. And what we think happens is that there develops a involuntary but abnormal attentional focus on parts of the body, on how your memory is working. And what distinguishes this from these causes up here of cognitive impairment is that whereas things here tend to kind of gradually improve, things here get worse. So the more people are noticing problems, the more difficulty they're getting into. You get people complaining of brain fog. And brain fog is, I have a research interest in functional cognitive disorders particularly. And people with brain fog, it's not that they're forgetting things and not noticing, it's not that they're getting lost and having to be brought back but not really bothered. They're really distressed by this acute awareness of how slow their thinking is and how effortful it is. And what we see in clinic is people with these conditions they tend to be more worried than the people that come to clinic with them, or sometimes they come alone and they give really detailed accounts of all the things that are happening with their memory, actually in a way that demonstrates that their memory is working quite well, but they are having these difficulties. And we think that this is probably often what happens is, so attention is absolutely crucial for your memory working properly. You need to have enough kind of brain power to allocate to the task at hand. If you're having a lot of symptoms, if you're breathless, if you are having maybe pain, chest pain, if you have a tremor or are feeling dizzy a lot of the time, then that reduces the amount of attention that you have available to give to any one task. It just uses up kind of brain power. Also, if you're anxious, that can impact on your attention. If you're thinking, what's wrong with me? This shouldn't be going on. Why am I still ill after all this time? So then what happens is that when you do fail a task, so you forget something, and actually we published some research last week about just how common it is for people to make healthy people to make normal memory lapses. We're all forgetting things all the time, but if you're really worried that there's something wrong with your brain and you forget something, then you get into this unhelpful cycle. You think, my brain's not working, I'm going to start making mistakes, I'm going to fail things. And we think what happens is that you start thinking and processing in a very, instead of in an automatic way, just like you usually would have, a really kind of effortful way. You're doing more thinking than you need to. You might be using more lists than you need to. Getting caught up in kind of really unhelpful things, which further reduce the attention that you have available for the task. So we think that kind of vicious cycle is important in the cognitive symptoms that we see in functional neurological disorder and in many of these cases of long COVID. So we think long COVID is probably going to be, and this is kind of speculative, we think it's going to be a number of overlapping different conditions. And it's going to be different early on. When you see somebody after 5 weeks, there probably is going to be a much bigger contribution of just, the leftover effects of the virus and the respiratory symptoms. And when we see people after maybe 6 months, 8 months, 9 months, it's perhaps more likely that you're either in one of these groups of older people who have developed complications, or people who've been severely ill who've developed complications, or younger people who've not been so severely ill but have developed a functional disorder. And the way that we think that we're going to be able to unpick that is first by looking at the clinical picture now. So we can identify functional neurological disorder. We don't do that by saying, well, we've done a brain scan and there's nothing there, or we've done the nerve conduction studies and there's nothing there. We don't do it by exclusion. We do it on the basis of positive features. So these kind of features in the cognitive examination of people being able to remember things in a lot of detail and yet being very distressed by these attentional problems that they're having. In other parts of the neurological examination, I won't go into it, but we've got various clinical signs that can tell us that this is reversible weakness that is related to the person's abnormal attentional focus. So we can look at the clinical presentation and identify what we think is going on. But then when we're thinking about treatment, when we're thinking about prognosis, it's going to be important also to look at what the person was like before, what kind of a track they were on before, their past medical history, whether they have a history of a lot of chronic disease that might make them vulnerable to cognitive impairment, to cerebrovascular decline, whether they have previous functional neurological symptoms, chronic pain syndromes, whether they've had problems with depression and anxiety in the past, and also if there's been any other kind of psychosocial things going on around the time of their illness and during their recovery that might be contributing to their continuing illness. And these are some of the kind of, and you're going to need to identify what's going on before you can provide the appropriate treatment. And I think what makes me a bit apprehensive is a lot of this long COVID recommendations coming out are saying we need to set up one-stop shop treatment services for long COVID as if it is one disease. And my view would be that people need a comprehensive assessment, but then they need to be signposted to the appropriate specialty for an appropriate treatment for what's wrong with them. So if somebody has had a stroke, they need stroke rehab. It doesn't matter that COVID is to do with COVID. If they've had encephalitis, they need the same sort of neurological COVID cognitive rehabilitation that they would have had they had encephalitis from any other cause. And we're used to treating these things. If you have a functional neurological disorder, you need generally rehabilitation, and that might include, that might be something that can be, if you've got a lot of fatigue, it might be something you can manage yourself if you're given the appropriate information and guidance. It might be something that you need help from a physiotherapist, and some people benefit from cognitive behavioral therapy that helps them sort of have some insight into the way they think about things and their physical symptoms and how they behave. So things like that boom bust pattern. So you need specialist rehab. Rehab for FND is best provided by people who've experienced at treating FND. So that's important. And the other thing is important to recognize things like PTSD, and also, I don't have it in here, but just anxiety and depression. There's a lot of anxiety and depression around at the moment for the reasons I talked about at the beginning, and treating them as you would treat anxiety or depression in any circumstance is really important. And I'd really emphasize, identifying PTSD is in people who've been critically ill. It's going to be really important because you can give them all the other sort of rehab in the world, but if they're still having these intrusive memories and this general hyperarousal, it's going to be difficult for them to make progress. So I don't think we need new services. I think we do need better investment in the services that we have, and it's difficult to find people in all areas of Scotland, for example, to give people quality specialist treatment for functional neurological disorder, and I find that very frustrating. I hope that if we are able to better recognise and acknowledge the contribution of functional disorders to some people with long COVID, that will kind of support the sort of parity of esteem of these disorders, get them better funding. And just a brief mention, so there was a sort of rapid response grant call at the end of last year, and a group of us in Edinburgh, Alan Carson, myself, and David Breen, some others, have won funding for a 2-year project, which is going to be recruiting 100 people with long COVID and doing really detailed investigations, brain scans, lumbar puncture, neuropsychological tests, to try and see if we can best pick out how to separate these different presentations. So we're really looking forward to that starting in the next month or so. I'm part of the Functional Disorders Research Group with John Stone and Alan Carson at the University of Edinburgh. My email address there if you've got any other questions, but I'm also happy to discuss. I'm kind of interested to see how this relates to your own work. So, thanks.
Thank you very much. I think that probably speak for lots of people to say that it's so interesting to hear that, and the way you've set it out in your slides is really helpful. And I think maybe the key thing that jumps out of that for me is that we are talking about symptoms that have been collected together and called long COVID, but we're really looking at lots of different causes of those symptoms. And I think what you're saying is you can't begin to treat those symptoms unless you know which route they've come, where they've what the cause of them is, and so we need maybe to be careful about looking at this too homogeneously. Would that be fair to say?
Yes, I think so. I think especially early on, I think it's more homogeneous and it's more leftover COVID post. But as months and years go on, I think this is going to turn into a range of different things. Yeah.
I think for me, that was so interesting in terms of, you know, as lawyers, the causation aspect of it, and thinking about pre-existing medical history, comorbidities, and trying to actually separate all of those things out. So, you know, was someone going to suffer from these conditions anyway, and has that, you know, what is the causation point on it? Really interesting. I think we're going to, you know, it's emerging, and we're going to have to grapple with that as these claims come in.
Yeah, I think it will be tricky. And I suppose there's also the question, especially in the first wave, most people didn't have any COVID testing. And the antibody tests they're not entirely reliable, so you get false positive, false negative. So I think actually establishing whether somebody's even had COVID might be difficult in some cases.
I suppose that leads on to the question, would it be possible for someone to develop a functional neurological disorder, which is long COVID, you know, that kind of symptomology, without actually ever having had COVID, because they've lived through the difficult situation, they've had the anxiety? Would it be possible to trigger this psychological reaction without?
Yeah, I think it's definitely possible, because we see these disorders all the time in people who have not had any kind of illness or stressful or traumatic experience. You know, they're probably, I think these are risk factors for going through COVID, and especially the kind of physical symptoms of it. They do increase this kind of internal sort of hypervigilance to your body that makes you more likely to develop FND. But we see FND developing in people who've not been ill. It's similar with mild brain injury. You know, we see people who have developed this kind of pattern of symptoms, and when you go back and look at the injury, it's been an extremely mild brain injury, or in some cases you find that somebody hasn't hit their head at all, but other things going on have kind of contributed to that when developing that pattern of symptoms.
And I suppose, Carly, just from the point of view, if you're looking at employers, it really underlines the importance of looking after how people feel at work. So, you know, you can have COVID secure measures that are preventing the transmission of infection in the workplace, but if people aren't feeling secure and they're feeling at risk, then you are exposing your employees to the risk of developing something along these lines.
I think that's right. I mean, I think you and I, going back to, you know, several months ago now, did a talk about what does safe actually mean. And in the context of COVID, you know, employers can take numerous actions and steps to put physical measures in place, but does someone feel safe? And I think, you know, there's so many other factors going on in people's lives that are playing a part of that the employer can't control. So again, it's interesting from a causation perspective.
Mm-hmm. It's also difficult to say what's normal in terms of anxiety at the moment, because I think, you know, I was mentioning yesterday, so, you know, there were videos early on in the first wave of people kind of hosing down their supermarket shopping before they would let it into their house. And if you'd seen that before, you'd think, oh, that's clearly somebody who has an anxiety disorder, perhaps obsessive compulsive disorder. But then in the first wave, that seemed kind of okay. So it's, you know, it's difficult to know what's normal.
Mm-hmm.
And one of the questions is, are there people that are more at risk for long COVID? So I think you're saying if you've had COVID, then you're more at risk because of the symptomology of that. But are functional neurological disorders something that you're vulnerable to because of your genetics or because of environmental things, like if you have pre-existing anxiety problems, or if you have been ill, if you have other chronic medical conditions, might those expose you to?
Yeah, I mean, there's sort of a range of risk factors, and none of them are very sort of certain or specific. In terms of long COVID specifically, I think the studies that have been done have suggested that people who have a lot of symptoms in the first week of their illness are more likely to develop long COVID. And again, that's just general long COVID. That's not specifically sort of a functional disorder. Women are more likely to develop it than men. And age also seems to be associated. So people who are a bit older. So yeah, and an older age group is sort of equal, women and men. Other risk factors for functional neurological disorders. So previous functional disorders, which are actually quite common, having other problems like irritable bowel syndrome, maybe chronic pain, people who've had health anxiety in the past. It's a bit more who've been back and forth to their doctor worried about different symptoms that there hasn't been any particular cause found, then that suggests that maybe they have been having some functional symptoms. And depression and anxiety, they're all kind of relative risk factors, but in any individual you would want to, I think before you could say that they would have developed it anyway, you would be looking for really quite a significant functional disorder or problems.
Another thing we've been asked, one of the questions come in is there any kind of delay between your recovery from acute, and I suppose maybe what you're saying is there isn't always a clear point where someone's recovered from the acute phase of COVID and then they have a gap and then they go on to develop long COVID, or is that variable as well, what you might see in a pattern of symptoms?
I wouldn't expect there to be a gap usually. I mean, well, you can see all sorts of things, but I think that the tail of acute COVID and it's going to be really difficult, and that's why I think that 4-week, 12-week thing is a bit arbitrary, because you know, breathlessness at 5 weeks, what is that? Long COVID? Is that acute COVID? Is it deconditioning from being ill? I think that it's going to be really difficult to set any, I don't think it's going to be possible to set a strict cutoff where you say this is the direct effects of disease and this is other processes that got going because they've been triggered by disease.
Yeah, so it's really deciphering it all is going to be the first challenge.
Yeah, I think it's going to be interesting.
Another question that's come in is there any central point at the moment in Scotland, I suppose, for diagnosis? Or I know you're saying that actually the treatment would probably be best dealt with in the specialist areas we already have, but that what a sort of single point that people come to in the first instance for long COVID?
So I think this is changing all the time. I don't think there is, but there is kind of a clinical pathway. So I think the GPs have access to certain additional, and I know that we are involved if there are particular neuropsychiatric concerns of people with long COVID, then I haven't been contacted by anyone yet, but there's a sort of network of a pathway for what happens with different people. So, and I think that is based on this, and I think it's a bit more sensible perhaps than what's happening down south, and it is based on this, people with respiratory symptoms are going in the respiratory direction, people with, so yeah, but I don't think there's a single point of contact, but the GPs are being kind of kept updated about what the plans are.
I think one of the things that's come in here that's interesting, and certainly from Carly and I's point of view, is how do you treat in the workplace, not just in a claims context, but when someone in the workplace has long COVID and from a Disability Discrimination Act perspective and making reasonable adjustments, you know, do you think that long COVID, and I don't know whether this is something you would have a view on, Laura, or really is it a disability? And so is it something that if someone notifies you they have, and would you be expecting an employer to make specific adjustments for it?
I think that's a good question. It would probably depend on a kind of case-by-case basis, but I think potentially there's disability there. But saying that, I think the emphasis should be in rehabilitation and getting back to work, because we would expect people to be able to rehabilitate fully from most of these states. So yeah, graded returns to work are probably going to be important in line with that kind of, you know, avoiding these peaks and troughs. And they in many cases might need to be more slowly graded than you would see in other, than you would be looking for if somebody's been off for any other kind of illness. So I'm not sure what answers your questions.
Sorry, I was just going to say, I find it really interesting, and when you were talking about the vicious cycle, because I think we see that in a lot of cases, you know, dealing with FNDs or brain injury, whatever it may be, you do see this vicious cycle that is perpetuated because the person does feel as, you know, they just can't get out of the cycle. And you talked about the rehab side of things, you know, just what, in terms of the key factor for trying to break that cycle, is it just getting the person to the right person in terms of what is the, you know, the main symptom and putting them down the right path?
I think so. I mean, it depends again on the person. So some people do quite well themselves once they've been given the diagnosis, and that's been very clearly explained to them. And they, you know, if they're able to use information that they get online, and people who are keen to get back to work are much more likely to get back to work. That's probably the key. I think, yeah, getting people in the right cycle, but generally reducing kind of fear avoidance. So people get into a cycle with all sorts of symptoms where they're frightened to do things in case they get the symptom. So they're frightened to do anything cognitive in case it damages their brain, or they're frightened to walk outside without a stick in case they fall. And it's just getting people out of that and getting people to sort of push themselves a bit to go beyond their comfort zone, because otherwise the comfort zone gets smaller and smaller and smaller. And that can be, and that's what we've found is, and there's been some good studies of sort of the different mediators of recovery in these kind of disorders. And it seems that whether you have physiotherapy or psychological therapy like CBT, what mediates whether you get better or not is whether your fear avoidance is reduced. So it's almost like you can either sit someone down and speak to them about their fears and help them to cognitively get around them, or you could be a physiotherapist and you scoop somebody up and get them walking a bit more regularly. So it kind of, it's not almost not the modality so much, you know, it depends on the person, as the just getting out of that cycle of fear and getting them doing things again.
And I think one of the challenges might be for employers then is just being more flexible about the way that graded returns are looked at in terms of their duration and the way, and it just maybe is like with everything in this pandemic, the sort of well-worn paths we have and the constrictions we see we have around us, we maybe need to think we don't, and we need to have new ways of approaching these problems.
Yeah, but you know, return to work I think is important for people. I think if you go, you know, going off work for a long period of time with these kind of disorders tends to be a bad, make things worse for you.
So getting back to work in
back
itself.
to work, but probably quite slowly.
Yeah, and I suppose that is it will be good for you to get back, but like Carly's saying, that this temptation to be like, I'm just going to go back in. Yeah, exactly. That will make me feel better is maybe recognizing that it won't if you approach it wrongly. There's a question here. I think you touched on this about antibody testing, and it's so saying if you didn't have a COVID, you thought you had COVID last year, you didn't get a test. Is there any point in looking for antibody testing now, or is really the reliability of that testing in terms of telling you if you've had a historic infection?
I mean, it's not terrible. I was having a look again this morning. So it's like if you have had COVID, it's very likely that your antibodies would be positive. But saying that, it is also, you know, there's a small possibility that it would be maybe 1 in 10 or something that you would have had COVID and it would be negative. Your test would be negative. And similarly, somebody who hasn't had COVID, rarely that could be positive. It hasn't been rolled out as much as I thought it would, antibody testing. And I think that's because it's not accurate enough for somebody to have an antibody test and say, oh, that's fine, actually, you can go about your business with no distancing or anything. And there's the worry that you get into bother because one person going about for a while contagious is really bad news. So I suppose if that is an underlying concern that's behind not pushing antibody testing, if we're out of the grip of the pandemic and that is no longer an issue, then antibody testing might then become useful for this kind of thing. It might be, yeah. I think though, again, as time goes on, once you're 6 months, 9 months past infection, actually it doesn't really matter whether you had COVID or not, that the treatment's going to be exactly the same. I suppose for you guys having to think about causation, it might be more important, but from our point of view clinically, at that point it doesn't matter to us. It's just getting the person better.
Yep. Okay, well, I think that covers off the questions that we've had in. I found that really interesting. I'm so grateful to you for coming along and spending your time talking to us.
No problem. A pleasure.
Thank you so much.
Thank you.
Thank you.